session, it's going to be on management of medication in elderly. So as we are aware, managing medication is a major part in providing care to the older patient. Polypharmacy is it's very common in elderly and is fraught with risk. We have here Dr. R. Thangam to enlighten us on this topic. Dr. Thangam is a senior assistant professor of geriatrics from Rajiv Gandhi General Hospital and MMC, Chennai. She's a lifetime member of Indian Academy of Geriatrics and currently holding a position of secretary of the same. Member and past secretary of IAG Chennai chapter. Involved in national and state level training programs for nurses and doctors in geriatric care and in emergency and toxicology training for primary and secondary care workforce. She has also contributed to the development of modules on distance education program on geriatrics by IGNO, authored a chapter on end of life and palliative care in elderly in a medical textbook by J.P. Brothers for postgraduate students. She's also a lifetime member of Asia Pacific Association of Medical Toxicology. Her areas of interest are geriatric intensive care, teaching, and research. We are so honored to have you here amidst us. Looking forward to hear from you on medication management in elderly. Over to you, ma'am.
Geriatric pharmacotherapy. 60+ population use medications thrice as much as younger ones with a high inter-individual variability. Multimorbidity is high, and so the use of one or more medications. And 1/3 of their hospital admissions are due to adverse drug reactions. And in addition to the prescription medication, they also use over-the-counter drugs and alternative medicines. And they are also subjected to so many transitional cares. Polypharmacy, which is the usage of 5+ medications, and hyperpolypharmacy, usage of 10+ medications, is very common in elderly, that too more in women than men. And this is also proven by various national and international studies. With this introduction, let us see a drug history of an older person. A 75-year-old elderly developed not improving with these 3 drugs. Carbamazepine was also added, but it was not working out for him, unfortunately. 1 week later, he was brought to the emergency department in a drowsy state with history of urinary incontinence and mobility issues. Examination revealed hyperactive delirium, retention of urine with overflow incontinence. Obviously, these are all due to as the adverse drug reactions of the drugs. So the prescribing in elderly is not the same as that of in a young person. That is mainly because of aging changes. The metabolism of the drugs changes with the aging. There is a change in the body composition, which leads to the differing volume of distribution of the drugs, and the liver and kidneys also undergo changes. There will be decrease in size, their function, as well as decrease in blood flow. All these changes will unpredictably raise the levels of the drugs or lower the levels of the drugs. And sometimes the toxicity of the drugs with lower therapeutic index will be very high, and the half-life of the drugs will also be unpredictable. Pharmacodynamics is not well studied, but it has been observed that there is a very high inter-individual variability. The 5M concept of geriatrics is the essence of geriatrics, and you would have heard about this from the previous speakers also. What matters most to the patient? Mind, that is mentation, the mood and the cognition, the mobility or the functional status, the medications, and multi-complexity are the 5Ms. Be it a new drug or a new therapy or any new procedures, all these 5 should be considered. The change in one M will affect the other M also. So what are the things we should consider before any prescription? We should understand the barriers which the patient and the caregiver will face in maintaining the compliance. We should beware of the comorbidities, common errors which can occur during the prescription of the elderly, use of non-pharmacological approach whenever it is possible. Instead of drugs, we can use the physiotherapy and the cognitive behavior therapy, etc. And we should always consider the risks and benefits of de-prescribing in elderly. The adherence to the medication is very, very important. There are patient and caregiver related problems and solutions for it. The problems could be the sensory in the form of poor vision and hearing, and the level of understanding because of illiteracy, as well as depression and cognitive problems, as well as mobility issues. They may be facing mobility issues in acquiring the medicines, and it is also due to the unaffordable cost. So whenever we start a medication, we should discuss with the patient about the need of the medication, probable duration, and the cost of the drugs. And if they prefer a less costly substitute, we should use that. And the written instruction should be given in a legible manner, or in an illiterate patient, it should be given in a, it should be discussed with them, and we have to make them understand. And the pill boxes can be arranged for them, and the usage should be taught to them. To maintain the monitoring, maintain the quality of the medications, we should monitor them. Medication review and reconciliation, both are not same. There is a slight difference between these two things are there. We should avoid prescription cascade. And whenever the patient develops any new symptoms, we should suspect drug interactions. Then we should be aware of the potentially inappropriate medication usage, and we should make use of the tools in assuring the quality of the prescription. So what is medication review? It is also called as brown bag technique. The patient will be asked to bring all the medications, including the prescription and non-prescription medication, health supplements, and all modalities of medication, be it the oral drug or the inhalational drug or topical medications, and it has to be inspected. This will help us to understand their knowledge about the medications, and we can fill the gap with their knowledge. And it will also give a glimpse about the drug duplication, as well as the adverse drug reaction, cause of the adverse drug reaction or the symptom the patient is having. And at the same time, we can arrange for the pill reminders, as well as the pill boxes to be used. That is, we can teach them how to use them and make use of them. And what is medication reconciliation? We can just see a story of an old lady who is having multimorbidity and who had suffered from a transition. She's a 68-year-old female, known case of systemic hypertension, diabetes, and coronary artery disease. And since she developed UTI, she had to be admitted. And her regular medications includes all these drugs. And you notice that she is taking combination preparation of telmisartan along with the diuretic, but we don't know when she is taking that. And she is also taking pantoprazole and health supplement containing ginkgo biloba, and on and off unknown over-the-counter painkiller as well as sedatives. And her investigations proved that she was having some infection as well as some mild dyselectronemia. She was offered injectables, including injectable rabiprazole and ondansetron. 48 hours later, she became better and she requested discharge, which is a common scenario. So she was prescribed oral antibiotics, and she was also given rabiprazole and domperidone combination. And she was asked to continue the regular medications for their comorbidities orally. But what happened? She was readmitted after 1 week with delirium and a fall at a home. This could be due to the drug duplication. The various drugs from the same PPI was prescribed to her, and her dyselectronemia was overlooked. She had been continued to take her diuretics, and there may be some drug interactions. All this has led to delirium, and she had fallen at home and she had to be admitted. So what is medication reconciliation? It is a process of avoiding medication errors across transitions by reviewing the patient's complete medication regimen at the time of admission, transfer, and discharge. And we have to prepare a fresh list medication regimen, avoiding all the errors. And we should also give a clear idea about this new medication regimen to be followed in the new setting. Prescription cascade. Let us understand what is this by an example. Suppose a patient has a hypertension. The patient is prescribed with calcium channel blockers. We all know that calcium channel blockers can produce pedal edema. instead of, and if you are giving a new drug for that symptom 2, that is drug 2, and this can worsen the patient in the form of dyslipidemia, and elderly can have the arrhythmia because of that. A drug 3 is introduced, and this can go on and on. This is called prescription cascade. That is using a drug for a symptom related to another drug. Another example is a person on behavioral disturbance prescribed antipsychotics developing drug-induced Parkinsonism, which resulted in Parkinsonian therapy and which precipitated hypotension and delirium in the same patient, which needed ICU care and even death. So,
ma'am, we have only 5 minutes, ma'am. 5 minutes.
Okay.
Okay, thank you.
Drug interactions are also very common. It is common in outpatient as well as inpatient settings. Female sex, advanced age, frailty and cognitive impairment and increased drug usages are some of the factors which can contribute to all these things. So how to avoid all these things? We have to write down the patient's medical condition or symptom whenever a patient develops a new symptom. And we should review the list of medications along with the new investigations and the procedures. And we should try to alter the dosage of the drug or think of an alternative to the drug. And we should also try de-prescribing and prepare a new list and re-evaluate the patient after some time for the disappearance of the symptom. This is called process map. And another thing is potentially inappropriate prescribing, where the drugs which we prescribe have more risk than benefits, and over-prescribing, where there may be duplication of drugs, and misprescribing, where we will not consider the other organ functions and resulting in serious problems like recurrent hypoglycemia with OHA. Then under-prescribing, where we miss out clinically indicated medicines. For example, in a patient with high risk of falls, if we ignore their bone health, this can result in fracture. So we have seen that vulnerable elderly are subjected to poor compliance, potentially inappropriate medication, drug interactions, and polypharmacy and prescribing cascade. We have certain frameworks and tools to avoid all these things. I have mentioned all these things. This is developed in various parts of the world and prescribed. And out of which 2 I will mention. Beer's criteria is endorsed by the American Geriatrics Society, where the medications that are potentially inappropriate and that should typically be avoided in older adults, the drugs to be used with caution, drug-drug interactions and drug dose adjustment based on kidney functions are listed, and we can make use of that. It is periodically updated. And this is stop-start criteria is where the potentially inappropriate medication is listed according to the physiological system, and it will alert the clinician when it is used. Similarly, if there is any omission, this start tool will alert the clinician. So these are integrated in various geriatric toolkits and also in the computer-based prescription system, so that as and when that prescription is given, it can alert if it is wrong. And it can also be available in apps which can be downloadable. So what is de-prescribing? This is a process of identifying or discontinuing the drugs in instances in which the potential harms outweigh the potential benefits. It will consider the care goal of the patient, current level of functioning, life expectancy, the values and preferences. Some drugs like PPI can be abruptly stopped, whereas benzodiazepines has to be tapered and stopped. And in a frail patient, we need not aim for a tight hypoglycemic control, and we can reduce the dosage of the drug. All these are called as de-prescribed. And though we have identified so many errors and how to avoid those with some tools, there are some deficiency in information and implementation. There is little evidence to guide the choice of right medicine usage in elderly, particularly in older adults with multimorbidity, because the trials will not include the older adults with multimorbidity, and the recommended doses for the young may be very high for women and frail individuals, resulting in drug interactions. And the low dose formulations, we advise usually to start low and go slow to achieve an optimum medication level. But these low dose formulations of medicines are not widely available in market. And these pharmacoepidemiological studies are community-based studies. This will detect the rare and delayed side effects to assess the long-term safety and efficacy. should be done in elderly population. It will be very helpful for them. So I will conclude my talk by giving a guide in way of a mnemonic. Whenever we use a drug, discuss the goals of care and consider what matters most to the patient. Review the medications periodically. Use the tools and frameworks to help to assure the quality. And the age-related changes, geriatric syndrome and life expectancy should be considered, and never hesitate to deprescribe. With this, I conclude my talk. Thank you very much.